Triplanar anteromedial closing wedge osteotomy in excessive slope and tibial valgus patients. We present a case of a young boy, 16 years old, 5 years after hamstring reconstruction of the ACL, never been really happy, coming for instability and pain. You can see here that the patient exhibits a ramp lesion, a very posterior tunnel, a root tear, and those elements and the tibial tunnel that was drilled at this time create a posterior epiphysiodesis with an excessive slope and a tibial valgus and a high patella. The Lachman test is very positive, as well as the rotatory instability of the knee. We only show you the osteotomy performed. The previous steps that were done are arthroscopic screening of the knee, femoral tunnels, cartilage and meniscus surgery. We're going to do an anterior closing wedge, creating both an anterior closing behind the tibial tuberosity and a medial closing to correct the valgus. It's a standard medial approach. We include in this approach the hamstring harvesting of the previous surgery. We dissect the deep fascia and the pes anserinus to assess the MCL completely. We then use a patient-specific cutting guide that would help us to create those different windows, the anterior one and the medial one. We verify the position of the key wires that's supposed to be exactly the same, the one on the planning. Once the PSI is secured into the patient bones, we do the different cuts. There is here 6 different cuts to be performed inside of the cutting guide to create the complete 2 triangles, the medial one and the anterior one. We then finished the different cuts using a small TPS saw to be less invasive and to be more accurate during the removal of the fragments. You can see here that we use first a chisel and this small TPS blade to be able to remove from the anterior behind the tuberosity and medial part of the tibia the 2 triangles to create the triplanar asymmetric cut. The idea is to close more on the medial side to correct the valgus and to close anteriorly behind the tibial tuberosity to create an artifact that will reduce the slope during the closing both anteriorly and medially. This is the aspect of the tibia once the closing is complete. When this step is acquired, we use a compressive plate specifically created for the ACL tunnels to be performed in between the proximal screws. We first securized the proximal aspect of the plate onto the bone without reducing the osteotomy. We use 3 locking screws. We verify the position and try to be as perfect as possible to avoid any conflict in between the plate and the medial tissues. When this is verified, after fluoroscopic control, we can then reduce the osteotomy site. The 3 screws are positioned, as you can see here, and we reduce the osteotomy site in full extension. And this first screw, which is positioned distally, is a cortical screw to create the compression anteriorly and medially and reduce both planes at the same time. We then securize the osteotomy with more locking screw surrounding the cortical screw, which is the gray one in the distal aspect of the plate. We then verify the position of each screws to be 100% accurate in terms of positioning, and we then drill the tibial tunnel, which is the last step of the ACL surgery. The position of the 2 proximal screws, the more medial and the superior one, allows to create a very easy tunnel without being bothered by any conflict in between the screws and the future position of the quadriceps tendon graft, which was used here. We present here the last X-rays with on the left the pre-op images and on the right the post-op images that are completely correct, both in varus and the slope. Thank you for your attention.